to learn something. We know that every surgical specimen for sure tells a story that does not just begin under the microscope, but at the grossing bench. So we are going to have an expert today who is going to who is going to make us understand the precision, the discipline, and the clinical insights required at this vital stage. So I'm hoping that we are going to enjoy. And if you have any questions, you can bring the questions at the tail end of the presentation. So you can help me now at this point to welcome our speaker, who is Christine Osale. And Christine Osale serves at the Department of Lab Medicine at Kenyatta National Hospital. And he holds a BSc in Medical Lab Sciences and also an MSc in Histocytopathology. So he brings a strong academic foundation, hands-on experience, and she also brings in practical expertise with deep insights into best practices in specimen handling, documentation, and even diagnostic accuracy. So with that, Christine, I hope you can hear me. You can say hi, and then we can just proceed.
Hello, everyone. Fred, kindly confirm that you can hear me.
Yes, we can hear you clearly.
Thank you. Hi, everyone. My name is Christine Osale, and I'm coming to you from Kenyatta National Hospital, Department of Laboratory Medicine and Histopathology Laboratory. Let me join my co-hosts for welcoming you to this particular webinar. And I'm going to be your speaker for the day and your host for the next 1 hour. So we can start. So today's topic is crossing of surgical specimen in histology lab. We are going to describe how to handle the tissue biopsies received in histology lab, understand of grossing or trimming of surgical specimens, and understand how to avoid cross-contamination during grossing. Introduction. Grossing or surgical prosection or trimming. The three words can be used interchangeably. You can say grossing, trimming, or surgical prosection. This is systematic macroscopic examination, description, and sampling of surgical specimen. Grossing, we know grossly. You're describing the specimen grossly. And then when you say trimming, it just means the cut up. You want to sample this particular specimen into smaller tissues that can fit in the processing cassette and allow the processing reagents to penetrate through during processing. So the three words can be used interchangeably. You have grossing, you have trimming, or surgical prosection. So what is a biopsy? A biopsy simply means a tissue that has been removed from a live body or a living body. And an autopsy is a tissue received from a dead body. So also autopsies can be grossed before they are processed. We don't only process the biopsies, we can also process autopsies, because autopsies can also aid in histological findings for the cause of death. Purpose and process of grossing. So grossing is important because it helps identify cancer, infections, or inflammatory conditions. During grossing, you are able to see whether the specimen, especially the whole specimens like mastectomy, kidneys, lungs, you can be able to identify tumor grossly. You'll not be able to tell which kind of tumor it is, but you'll be able to tell that this particular specimen has tumor. So grossing also helps in diagnosis. And it's always important that grossing is done by a pathologist, but it can also be done by a technologist, especially for technologists that are running standalone labs. It's always important that for histology, it's always important to understand the basics of grossing, because you cannot hire a pathologist to come and gross for you. You will have to gross your specimens, process them, and then they just avail slides for reporting to a pathologist. So it's important that as the MLOs, we also understand the basics of grossing. We don't leave these particular aspects to pathologists alone. And then grossing will also help us determine the staging of the disease. It determines how far the cancer has spread and it's spread, because you'll realize that some specimens that are being delivered in the lab, they are coming together with attached tissues, like maybe you're having a breast plus axillary dissection from the armpit, or you're having a uterus and then you have a omentum from the abdomen. So they want you to identify if there are any lymph nodes in those particular attached tissues, and they'll help you in knowing whether this disease is spreading or not. If it's cancer, is it in situ or
Christine, I don't know whether you can move closer to your device. You are now not very clear. I don't know whether you've moved far from your device or what, but maybe you can check. You are very clear, but all of a sudden now we are losing you.
Am I that clear right now? Hello?
Can you just confirm you can hear me?
Yes, hear you loud and clear.
Christine? Can you confirm that you can hear me?
Hear you, Fred. I can hear you. Are you able
Yes,
to?
now you're.
Yeah.
Can you come up again?
Right now.
Wow. 1 minute you are good. The other minute we lose you. Can you hear me? Can you just confirm again?
Yeah, minute. Are you able to hear me right now? Hello?
Now you're very clear. Maybe you can just maintain where you are and the distance between you and your device now. It's very clear.
Okay. Thank you. So I continue from the same slide, or I just one?
Yeah. Yes, just on the slide where you are.
Mm-hmm. Okay,
Yeah,
thank
maybe
you.
you can. Yes.
Thank you, and sorry for that. So we say that grossing is important in diagnosis, in staging, in analysis. The samples can be analyzed macroscopically even before the samples are processed and analyzed histologically. And then most of these samples are normally taken under local anesthesia. So when you talk about samples being received, histology samples, and when they're being delivered in the laboratory, there are some key details that should accompany this particular sample. The sample should be delivered having full patient names. If there are 3 names, it's important that the sample has the 3 names, and always patient hospital identifier. It's very important, because we know we don't want to mix histology samples. Giving someone a uterus, saying that this particular uterus is for this particular patient, and yet the patient already still has her uterus, and the person that the uterus was taken is not having results. So patient's hospital unique identifier is very important. Clinical diagnosis, this one is very key, because during grossing and even histologic reporting, we want to correlate clinical findings, what we are seeing macroscopically and even microscopically. If a clinician said this particular patient has cancer, and yet during grossing you cannot see any tumor, you just indicate there are no tumors seen macroscopically. And then you process the specimen, and then you examine microscopically. If your still no tumor is seen, then the pathologist will be able to write there the report. We just report, and then you say a repeat biopsy is indicated if it is recommended if indicated clinically, because the clinical diagnosis says it's cancerous, but the histological finding says it's not cancerous. So the pathologist will just be able to write there, a repeat is recommended if indicated clinically. Then the patient age and gender is very important, and this one also helps in statistics, because when even doing when you're doing a statistics for a particular case, maybe breast cancer, you want to see at what extent the male gender is affected, and at what age is these cases being picked. Then the ward or source of the specimen. If it's from the same hospital, the ward is very important, or the theater is very important, so that you can track back in case there's information missing, or you need additional information, or you need imaging information, because diagnosis of histological reports of biopsies or cancers, it's normally based on triple assessment. You have to account the clinical assessment, the imaging assessment, and then the diagnostic findings. So all this information is very important, especially the source of the specimen, because you might need to refer to the imaging. Then tissue description. It's very important to say that this particular tissue is from this particular part of the body, so that you don't just take tissues and then you put then they put there, because during grossing, you're not even able to tell the tissue I'm having, is it an appendix, is it a breast, is it, you are supposed to, the tissue description is supposed to appear on the request form. If it's not, the person receiving that particular specimen is able to call the specimen and try to find out what kind of tissue is that. Then the specimen is supposed to be delivered in adequate fixative, because we said all biopsies should be fixed immediately after removal from the body. If you don't fix, the process of autolysis will begin. And when the specimen is reaching the lab, it will already be autolyzing, it will be smelling, as it will not be able to give a good histologic report. So all specimens should be fixed adequately. If you receive a specimen in the lab and it's not fixed adequately, it's just important that you put the fixative. You should be having the fixative ready. You put the specimen, and then you indicate on the specimen that it was received unfixed. Remember, in histology lab, we don't reject specimens. We only do troubleshooting, because if you start rejecting somebody's uterus and they need a diagnosis, you cannot get another uterus. It's not like blood, whereby you're going back to get another sample of blood. You say that this one is clotted. No. In histology, we don't reject. We only troubleshoot. What are this type of specimens that are being received in laboratory, in histopathology laboratory? We have excisional biopsies, and this one is whereby an entire lesion is removed. You're having an entire lesion, then you remove it. Maybe you do a lumpectomy if it's from the breast, or whatever it is, you just remove it. From the screen, if you can see, there's a lesion here in this breast. So if you want to do an excisional biopsy, it means you're going to remove the entire of the lesion. Then we have incisional biopsies. Incisional biopsies is whereby you go inside the lesion and just take a small portion or a representative portion of that particular specimen. Like the one that is being taken right now is a core needle biopsy. This is a core needle. So you just use this one to take a core needle biopsy from here. So just take a representative specimen. Then we have punch biopsies. This one is normally performed in dermatological procedure, whereby a small cylindrical skin sample is taken. There's a small equipment that is cylindrical with a depth of around 2 millimeters that is normally used to do punch biopsies, mostly from the skin. And then we have curettings. This one is whereby tissues are removed from the inner lining of the uterus. and it's normally performed under D&C procedure. D&C means dilation and curettage, whereby accurate, that's a particular equipment that is used to take the sample from the uterus is called accurate. You use accurate to get some scraping from the uterine wall when the person is having uterine abnormalities. Then we have shave biopsies. Shave biopsies, again, mostly done in dermatological procedures, whereby there's a raised skin lesion. There's a raised skin lesion, you just remove it by a blade. It's normally called a shave biopsy. And then wedge biopsies, these are small V-shaped slice or chunk of the specimen. Like here, if you want a wedge biopsy from here, you just remove something that will cut through the skin, the lesion, and then back. It will be something like this. It will be a wedge biopsy. Then we have endoscopic biopsy, whereby you use an endoscope during an procedure to get samples from the gut mostly. So the endoscopy are normally the ODP. That is the biopsy.
Hi, Christine. Christine, we lost you completely. I don't know whether you can hear me. Christine, you can just confirm that you can hear me. And also the participants can confirm that they can hear me so that maybe.
Yeah, you, Fred.
Well, I don't know what's we keep losing you.
I can hear you.
I think, can you just go back to 2 slides? We began losing you from there, yes. Then
From
we
here.
lost, yes, then we lost you completely. So maybe you can check if it's your network or something. But I think from where you began speaking about the principle, now we lost you completely.
Sorry about that. Am I audible right now?
Right now, you're very audible. Yes. So from here, we lost you completely. So maybe you can.
Let me just brush through. It's fine. No
Yeah,
worries.
please. Okay.
So, kindly let me know because my network feels like, okay, I don't know. Just let me know. Okay. So, calls for grossing, but fixation is very crucial. You must ensure that the biopsy is well fixed before you proceed to grossing. If it's not fixed, it will not be, even handling manipulation becomes hard, especially if it's a big specimen. If it's a smaller specimen, even if it's not fixed, you can just do the cut up and then allow it to fix before you start processing. So for the big specimens like the breast and the uterus and the kidney, those whole organs, you just have to slice them. We call it bread loaf. You slice them and then you allow them more time for fixation in the fixative before you start processing. For the smaller specimens, always they fix very fast. So those ones will not give troubles. Then the larger ones, they need to undergo more. They need more time to fix well, and then slicing or bread loofing will facilitate the fixation. So these are the grossing equipment that you'll need. We have scalpels for doing the cut up, those smaller slices of around 2 to 3 millimeters. We have the forceps for holding, help to hold the specimen during grossing. We have the knives. Knives, we need them for bigger organs, for bigger tissues or whole organs. And rulers for measuring the biopsy. A grossing station, and the grossing station should be well ventilated. Tissue marking dies for marking the margins. You need cassettes for placing the sampled tissues for processing. You'll need a pathologist and a technologist, or a technologist alone. Then you'll need a pencil or a pen, that's a slide labeling pen, or labels for the digital labs. Then you need weighing balance and filter papers. Filter papers are for holding those very tiny specimens to avoid losing them. If you don't put them in filter paper when you start processing, most of them will disintegrate and will disappear. And then when you go for blocking, you'll realize you're having nothing in the cassette. So this particular patient will not get a histology report. A repeat biopsy will be recommended. Facilities and safety, you'll need high-grade ventilation to remove the hazardous formalin fumes, because formalin is very hazardous to human health. And then you need bright light, because if you should be having a bright light to be able to identify tumors and also to be able to see those very tiny tissues. You need integrated sinks, and for personnel, the personnel must wear the appropriate wear. And then we have PPEs. You should, before you start grossing, wear the PPEs. We'll have the aprons or the gowns, then the gloves. You have the surgical gloves are recommended here. because of their high chances of cutting yourself using the when you're cutting the tissues using the scalpel. You need face mask or face shields. All these tissues grossing here should be treated as you should handle them as if they're potentially infectious or hazardous. Verification and triage. This one is normally done. You need at least two people, a technologist and another technologist, or a pathologist and a technologist. One is going to confirm the details on the request form, and the other one is going to confirm the details on the biopsies specimen container. The names should be matching. The number that has been assigned, the lab number, should be matching, because once a specimen comes to a histology lab, it's normally given a unique identifier in the lab. And that number is the one that will identify that particular specimen or that particular case. You don't go and ask, I want a report for so-and-so. No, you just look for that particular case number. So the case number should be appearing on the container and on the request form. Then after, if there are any discrepancies, if you realize they're not like matching, then you solve. You have to troubleshoot, you go back before you continue. If they're matching, then you can proceed with your grossing. Sorry. So the first thing you're going to do is to try and orientate your specimen. Is a big specimen. On the grossing, on the grossing hood, on the grossing table or surface, should be able to orientate the specimen. If you're having, it's like a breast or even a thyroid, you must be able to tell whether it's a left thyroid or a left breast or a right breast. In most cases, if you can be able to see this particular specimen has been marked with some sutures. They mark the suture, they'll put a suture, and then they tell you this one is superior. Once they tell you this one is superior, you'll definitely know the lower part is inferior. And then you'll be able to know where the lateral margin is and the medial margin. And then the surgical margin, the other side will automatically be the deep margin. The margins are very important because, especially for this particular specimen that is on the screen for a breast, they're very important because you'll be able to tell if the tumor is perforating the margins, if the tumor has infiltrated the margins, if it's touching the deep margin, that means the surgical margin is not free of tumors. So there's some tumor that remained on the patient. So this one is very important. You have to orientate it, then you mark using the ink, like the tissue marking dies that you have seen. You mark the margins. So with macroscope, this one, we normally try using the 5 speed.
Christine, we lost you again. Christine? Christine? Can you hear me?
Hello?
We lost you again. I don't know whether maybe you can check on your network because
my network is full and hello? Are you able to
yes.
hear it? My
Can
audible
you try
right
that
now?
again? Yes, you
My
are, but you begin speaking and then in like 3 minutes you again disappear completely.
Sorry about that. Am I audible right now?
Yes, you are audible. Can you just go back to the previous slide?
This one. Sorry.
Yes,
So,
please.
okay. I'm now audible.
Yes.
Okay. So the orientation, before you start, you have to orientate your specimen.
Can you go to macroscopic examination? Macroscopic description, yes, there.
Okay, so that's where I was, right? Okay. So we start the macroscopic description of the specimen is normally done using 5 C's, whereby the 5 C's stands for color, contours, consistency, meters, at surface. Color, you describe what you're seeing. Whatever color that you can see, like this specimen, you just say it's brown in color with yellow areas, which describes the color that you're seeing. Then the contour means the shape. How is the specimen? Is it round? Is it oval? Is it lobulated? Is it irregular? You describe whatever how you're able to see the specimen, because you'll find some issues like the uterus, when it is distorted with fibroids, it becomes lobulated instead of being oval. So just describe what you're doing, what you're seeing. You'll be able to describe whether it's hard, soft, firm, friable, or necrotic, because if it's hard, that tells you have to decalcify the specimen before you start seeing. For instance, if you're having a bone or a tooth, it will be hard in consistency. The specimen will have to undergo some decalcification. Then the in centimeters simply stands for the measurements. When you are measuring the specimen, you give the measurement in centimeters, and along with the measurement, you give the weight. If the specimen is whole, you have to weigh the specimen, because you'll find some specimen when they have tumor, they'll be even 3 times the normal size of the normal size. So you have to weigh the specimen. Then cut surface. You will cut the surface. You will cut the specimen into 2, and then you'll be able to describe the cut surface. What are you seeing in the cut surface? Is it cystic? Appearance, just describe the appearance, how it is, the color of the cut surface, the consistency of the cut surface. Does it contain any fluid? Describe all that. Then the sampling. This is the cut up. Thereby, after you've done your description and all that, you will start the cut up of the specimen. And then you take the representative section from areas of interest. You just don't take sections like blindly, grossing, take from areas of interest. And for pathologists, there is always a guide on how they are sampling the specimen, not even for pathologists alone, even for technologists. There's always a guide, there's a book, Ackman's, which gives you a guide on how to sample, which areas are you going to sample. If you're having a uterus, of course, you have to sample the cervix this way. You have to sample them, endometrium like this. You have to say if the ovaries are attached, and you sample from both ovaries, from both tubes. You have to sample all those areas. So you take areas of interest. If it's a breast, you'll have to take from the tumor, if there's a tumor there, and then you sample from all the margins. and then you sample the nipple, and then you sample the lymph nodes. If you're having lymph nodes, if you harvest any lymph nodes. So there's a guide on how to sample. Once you start, you feel like you want to open a lab, you can look for that guide, and it will guide you on how to sample all the specimens, only in alphabetical order. But areas of interest must be sampled. You get representative sections from the tumor, then you sample from the margins, and then you sample from the random, you take some random specimen from the normal tissue. Yeah. And the sampling, when you're cutting, the tissue that is being cut should be 2 to 3 millimeters thick. Don't cut big tissues. If you cut big tissues, they're not properly, and they'll cause a problem during microtomy. So sampling is very important, and you have to cut them into thin slices of around 2 to 3 millimeters. Documentation. During grossing, the notes, or for the digital people embracing digital pathology, you'll find that during grossing, you really don't have to have someone to take the notes for you. You just dictate the notes. As you sample, you dictate the notes, and they are being saved. But if you've not reached there, then someone should be, if you're grossing the big specimens, someone should be taking the notes for you, and you prepare a block key to track exactly which anatomical area is in which cassette. For instance, let me go with the breast. I like talking about the breast. So for instance, if you are grossing the breast, you will say cassette 1, 2, 3, it's the tumor, represent the tumor. And then cassette 4, superior margin. Cassette 5, inferior margin. Cassette 6, lateral margin. Cassette 7, medial margin. Cassette 8, the deep margin. And then cassette 9 is the nipple. Cassette 10 to 15, lymph nodes. So that is a block key. When you process that way, and you see this documentation, this one serves like a permanent record. You can always refer to it. You wrote it down, and that cassette contains the specimen from this particular specimen, this particular area. So you have to keep this as a permanent record. It will always refresh your mind. If you want to go back to that particular specimen, maybe in future, maybe the diagnosis did not match what was there, you have to go back to it. You'll just find the block key there. So there are some sampling techniques, common sampling techniques, whereby you do perpendicular sections, you cut perpendicularly into the tissue, then you sample that way. And then you have the end face, or the tangible sections, whereby you cut sections on the resection, parallel to the resection margin. Resection margin is whereby the tissue was cut from the body. So you cut section parallel to the resection margin. And then you have bread loofing. Bread loofing is whereby those big specimens are not well fixed. So you will slice through them. You cut just parallel lines into the specimen, and then return it into the container in appropriate, in adequate fixative, and allow it to fix well. Then handling of small biopsies. Small biopsies like the core biopsies or the endoscopic biopsies or the curettings, the endometrial biopsies, those ones, you just describe them. How many biopsies, how many cores do you have? If there are 5, it's always important that you say the number, because and this one also helps even in blame games, whereby you say that the specimen was inadequate, and then the surgeon is telling you, I took 8 biopsies, because they'll have their record. So it's important you also have your record. During the grossing, whoever is taking the notes, then you'll tell the person to write 4 biopsies, the number of biopsies. If it's 4 cores, 10 cores, it's important that you count them and you document them. And then after that, smaller biopsies, they are normally ink. Ink is your then after you ink with your and then you fill paper. Fill paper, you will always avoid using this specimen during testing, and you will also avoid you're having
Christine? Christine? We lost you again. Christine, can you confirm that you can hear me?
Yes, I can hear you loud and clear.
Yes, we lost you again. Maybe you can check your network, and maybe if I don't know what you can do about it, but just check. We can hear you now. Can you just proceed?
Slide.
Okay, we can't hear you.
On slide.
Christine?
Yes.
We
Hello.
are sorry. We are doing very well, but on this current slide, we can't. We have lost you. Can you come up again?
Right now, are you able to hear me?
Yes, right now you are clear. Can you proceed?
Sorry about that. Okay, the whole slide or the last bit.
Yeah, just the last bit.
Okay, speaking of smaller biopsies, I've said the small biopsies, especially the cause, that you count cause for the endoscope, like the OGT tissues, and say I have 3 tissues or 4 tissues or 5 cores, because you might be blamed for having lots of tissues in the lab by the surgical team. Always make sure that there, and if you have 10 codes, count all of them and say I'm putting them in 4 sets or 3 sets, and then you ink them.
Christine?
You add yes.
Christine? Yeah, you are breaking. Either the network keeps on buffering or something, so that I don't know. Can you just come up again and maybe we try and see how it goes? Just proceed again, because we were beginning to lose you. Just proceed.
Yeah, hear me?
You are not audible enough.
Able to hear me right now?
Okay, we can hear you, but from very far. I don't know whether you can move closer to your device. You are not audible enough. Okay, can you try now?
Hello.
You are clear now. Can you proceed?
For small biopsies, always count them and put in filter, add ink and put in filter papers to avoid losing the specimen. And for identification, especially during embedding, because we always embed in molten paraffin wax, which is white when it solidifies. So if you're having small tissues, like the gastric tissues or the core biopsies, and then you just place them in the filter paper without adding ink, someone whose eyesight is not so good will not be able to pick them up. You might lose them during even blocking. So it's always important that you add some ink, mostly eosin, because in the long run, histology tissues, the standard staining procedure is H&E, hematoxylin and eosin staining technique. So if you ink the samples, the small samples with eosin, it will not have issues. You'll not be able, you will not, the ink will not affect the staining or the macroscopic visualization of of the specimen. Don't use the tissue marking dyes for small tissues, because those ones, when you mark, they'll be visible even under the microscope. So it's just important that before identifying, you use eosine. Then loading, samples are kept in labeled cassettes. Like I said, once the person on the grossing table starts saying cassette 1 to 3 tumor, you write. This cassette should be having the number of the case here, whether it's writing by a pencil or it's printing. If you have a barcode printer, just feed the details and it prints the label, and then you stick here. Then you say cassette 1 has this particular part of the tissue. Cassette 2 is having the left margin or the surgical margin. You label like that. And then you cut the specimen into smaller pieces of 2 to 3 millimeters, and then you load in the cassette. Avoid overloading the cassette, because if you overload it, the specimen will not fix properly. So smaller tissue of around 2 to 3 millimeters into the cassette. How do we avoid cross-contamination during grossing? First, you ensure that the grossing station is cleaned in between cases. You finish with one case, you clean. Just allow running water to clean, so that you don't pick the remaining material on the grossing station when you're grossing the next case. And then this particular case had tumor. The case you're grossing, you're working on, does not have tumor, and then you realize that there is contamination. When you go look under the microscope, you're seeing some areas with cancer cells. You clean them by trimming steps to use whole tissues, all the tiny tissues. Some tissues may just stick on the forceps. Kindly clean them in between cases. After one case, you clean. After one case, you clean, so that you don't have carryover to contaminate other tissues. And then the tiny tissues or tissue fragments are placed in filter papers. Why are you placing in filter papers? To avoid contaminating other tissues during processing. Because the process, if you're using an automated processor, is that continuous agitation of the tissue fragments. The tissue is being processed. The agitation and high temperatures may make tissue fragments to spread. These tiny tissues or tissue fragments are normally placed in to avoid contaminating other tissues. And then
Christine, we lost you again completely. Christine? Christine, can you confirm that you can hear me?
I can hear it. You're not able. Hello?
Yeah, there was a position you had. You were in some particular position that was very good. And now we have lost you completely. Maybe you can try. I can hear you are a bit clear now. I don't know whether you can try maybe from there. We see how it goes. No, we can't hear you now.
Oh.
Can you come up again?
Hello, you are able to hear me?
Yes, but though not very clear, but just proceed, because I can see our time is far much spent. Just proceed.
I'm not clear.
Now you're clear.
Okay. Okay. So for avoiding contamination, you have to clean the tissues. You have to clean the grossing in between cases, and then ensure also the cleaning, the trimming equipment, the forceps, the blades, the knives are cleaned in between tissues. Any tissues or tissue fragments should be placed in filter papers to avoid them from spreading to other tissues or contaminating other tissues. And then it's very important that you attend to only one case at a time. Yeah, I've seen when we have like 2, 3 students or registrars trying to learn how to gross, you'll find one attending to another, the other attending to another case in the same grossing station. That one might lead to cross-contamination of specimens. And then this, in many training programs for the grossing, we use the prime model. So when the prime model, there are 5 questions that are normally asked using the during the trimming or grossing process. First, why was the surgery performed? Why? A physician must have given you the clinical history from this surgery because this particular client, we're suspecting that they have cancer or it's a lipoma. Ask yourself, why was it performed? The clinical history is very important. Then the relationship, where is the lesion related relative to surrounding organs and landmarks? Where is the lesion? If it's on the breast, is it to the margin? Is it the superior margin, inferior margin? Where is it? And then the internal, when you cut the surface, you describe the cut surface. How does it normally look like? The margins, how do the surgical margins appear? They appear, are they like are they part of the tumor or they're free of tumor? External initial assessment of the tissue type and orientation is always as received. That's just orienting the specimen before you start the cut-up. Common pitfalls and best practices in grossing. First, you have to avoid overloading. Cassettes should not be crammed with tissues to allow proper reagent penetration. Inking of the margins, essential for identifying tumor proximity to edges, particularly in cancer cases. Always wear personal equipment. Loading cassettes, the tissue basket. These cassettes that you've done, depending on your workload, they might be many, they might be few. Sorry. There are some labs that will process up to 400 or 500 cassettes in a day. There are some that will process just a few cassettes in a day, like around 20 or 30. So you have to arrange your cassettes well in the tissue baskets in a manner that will allow the processing reagents to penetrate through and reach each and every cassette to process the sample that is inside. Then once you load the cassettes in the tissue basket, the tissue basket is this one. These are the cassette holder. You leave them in 10% neutral buffered formalin for further fixation for up to 6 hours, especially if you're having those big specimens. Then you can process the tissues either manually or using an automated tissue processor. Conclusion. What is the importance of this process? Why is grossing so important in histology? Accurate cancer staging, because you'll be able to see if you're having any lymph nodes attached. Margin assessment, if you're having assessment, and during grossing when you cut, you can tell whether the margin is involved in tumor or it's free of tumor. Identification of the tissue, you will be able to see which particular tissue to sample. And then safety and traceability. When you're grossing, the record you create during grossing, that is a permanent record. You are able to refer to it. It will be archived when you go to the labs that the records, you are able to find the records even as far as 10 years back. And you'll be able to say, this particular patient has a mastectomy removed, and we did this and this and this, and this particular cassette is having tumor, and we use this cassette for IHC. So it's a permanent record. Grossing is very important. And then it's guidance for further testing. During grossing, when you're doing the macroscopic description, you'll be able to tell whether you need other tests like the special stains. You'll be able to say maybe this particular test looks like it has undergone inflammation, so we need to do ZN or this and this. You'll need to know whether it's having mucoid. Maybe it's a colon and there's so many pus. So you say we are going to do a PIS to see if there's fungal infection. Then during grossing, you will be able to tell whether the specimen was properly fixed. And if it was not, you can now allow it to fix before you start your processing. And thank you for listening. Back to you, Fred. Fred, back to you.
Then yeah. Christian, are you able to hear me?
Back to you, Fred. Hello.
Yes. Hello. Are you able to hear me, Christine?
Yes, yes. I
Oh,
can hear
great.
you.
This is George. Thank you very
Okay,
much
George.
for the great presentation. I think at this point, we are moving to the section for questions, reactions, comments. And before I open the questions, I would like to inform all the members that maybe for those questions that needs more explanation, you can just raise your hand. You tap the raise hand icon, and then you will be given the chance to talk, so that you can have that privilege. Without much ado, let me check the questions that I hear in the comments. I have to acknowledge that most of the members are appreciating your presentation. This is very great. Faith Joguna is saying great presentation. Thanks a lot. Daniel Tomno is saying excellent presentation. So they are quite encouraging. Bahati Oremwe is appreciating and is saying that indeed a true representation of beauty and brains at work. Histopathology, my favorite. I'm scanning through to see if I can see any question, but I can only see everyone appreciating your presentation, Christine. So this underscores the level of research and the time, the duration that you took to ensure that your presentation is well researched and full of knowledge. And this is quite encouraging. Akaka Leonida is saying, if only histopathology could be practiced and embraced in most labs, the experience would be on another level. Otherwise, very good presentation. This is wonderful. Christine Musioki is requesting for slide, but I would like to inform Christine that this session is being live streamed on YouTube, and if you'd like to maybe review some of the areas, kindly follow us on YouTube, or you can just go to YouTube and type the title of this session, and then you'll get all the presentations, and the video is there all through. I think at this point being that I can only see appreciations. Let me see if there's somebody who maybe has raised a hand. Okay, great. This okay. Personally, I would like to appreciate you, Christine, for this work and also this moment, the session that you've covered. Your presentation is thought-provoking and full of knowledge, and you can check the comments from all members. They actually attest of the same. And okay, I can see Japheth Kiplimo Kosgei is asking a question. What are the requirements or protocols to be adhered to ensure more, I don't know what you are trying to write, but say more lab-heavy histology sections? What are the requirements for protocols to be adhered to ensure maybe accuracy or I think you can come out clearly with this question. I don't know if okay, I think it has been brought down. I don't know why I can see it anymore. It's okay. It's okay. It's okay. You can just let your questions come. I saw Mose raised his hand. I don't know if Mose, you have something to say? Mose?
Hi, George. Hello,
Okay, good. Yes, I can hear you. So,
George. Hello,
yes,
George.
Christine, I
You
can
can hear
hear
me?
you clearly.
I think I understand the question that is being asked here.
You've understood it, great, okay.
The protocols to be adhered to ensure labs have histology sections. So
Okay, oh good. So you can respond to it as we move
yes,
forward, okay.
yes, the protocol you have to ensure that are not called histology. People always treat histology as if it's a unique section. Yeah, we are unique. It is unique, but you can start it anywhere, even in a standalone lab, even in a routine lab. You can set up a histology section. And histology, actually, our consumables are always very cheap and they're easily available. You really don't need to have those huge equipment. We don't have like complex protocols. Actually, you can even do grossing in a sink, so long as you have the right PPE. Just make sure that your sink is connected to somewhere whereby the formalin, maybe you can connect your sink to a pre-treatment tank whereby the formalin goes to be treated first before it's released into the normal system, because formalin is very hazardous, and also xylene as well. So those two chemicals, so long as you have a proper system of handling the two, you have to make sure that you handle them very carefully. And then for the samples, you must have a proper disposal system where you'll be disposing your specimen, because specimen is not like the biopsy is not like blood you're going to throw in the bin, in trash. Maybe you must have a proper system whereby maybe it's picked and incineration is done. You can even liaise with a bigger laboratory to be picking your specimen for you, and then they go and incinerate. So the protocols are not, so we don't like so long as you comply with the requirements of the board, protocols for histology, and you just need H&E for the stains to start up, and then formalin for fixation. You can start by processing manually, whereby you just do the processing manual, using the manual method. You'll buy the equipment as you go on. So there are no like so special protocols. So long as you understand the procedure and you have your systems in place, you're good to go.
Great. That's wonderful, Christine. There's another question here. Simeon Letin is appreciating your presentation and is asking if the sub-studies maybe you have touched on, and he's asking that if these studies can supplement gene matching studies, especially in criminal investigations. So I've just read it the way it is, but there are areas on studies, and he's asking if can they supplement gene matching studies. Great. About the studies you have presented on, can they supplement gene matching studies, especially in criminal investigations? So, Christine, maybe if you can get what Simeon is asking from your presentation, is there any area that maybe some findings can supplement gene matching studies? Kristen, you able to hear me? You can hear me?
Hear me?
Yes, I
Yes,
can
I
hear
can hear
you.
you.
Yeah. All right.
Yeah.
There's that question
Yes, I've seen it.
by Letting. Oh, great.
So, trying to say here is, I'm not so sure about the studies he's talking about, but if it's histologic, and if histologic and gene matching studies, it's very possible because you can do PCR on tissue blocks. So it's very possible. Yeah.
Okay. Okay. Yana Kutete is asking a question here. Apart from macroscopic description, do we have microscopic descriptions based on the 5 C's? Apart from the macroscopic description, do we have microscopic description based on the 5 C's?
No, no. Microscopic description, under microscope, it will be now what you are seeing, the real picture of the tissue under the microscope. And then you'll be able to relate that particular image, what you're seeing under the microscope, with what you described macroscopically during grossing. So you don't describe the tissue using the 5 C's microscopically. No. Microscopically is the cells. What you're seeing, how do the cells look like? How is the surrounding of the cells? Because you cannot start saying the measurement of the tissue under the microscope. No, you can't. You.
That's wonderful. Thank you very much. Now, Robert Rono is asking a question about storage. Now, for how long should a tissue or biopsy be preserved or stored in histopathology lab? For how long should it be preserved?
Okay. Okay. Based on your workload, the tissue, the biopsy cannot be discarded until the report is out. That one must be noted. You have to wait until the final report is out. And then, based on your workload, each particular lab will come up with a standard operating procedure on how the archival of blocks and tissues is done. Some labs will say 1 month after the final report. Some other labs will say 2 weeks after the final report. Some other labs will say 3 months. The standard is 3 months after the final report, the standard. That is the standard archival period. 3 months after the final report. But based on the workload, if you don't have space to keep those issues, once you are done with them and then the report is out, you give it 1 month and then you discard. Yes, hope I've answered.
Thank you very much for that. Now, this is a question that concerns trephine biopsy. How do you handle trephine biopsy in terms of grossing? How do you gross a trephine biopsy? So this is a question from Samuel Siriba.
Okay, so for that, for the biopsy, most of the time it comes as a core biopsy. It comes as a core biopsy. So once it reaches the lab, you treat it the same way you treat other specimen during a reception and accessioning. You assign a lab number, and then during grossing, you describe the specimen the way it is, the color, the size. You measure the specimen, the core biopsy. That is just a core biopsy actually. Then, if it's big enough, you just put in a cassette. If it's not big, you put in a filter paper, then you put in a cassette, and then you put in a fixative. This trephine biopsy contains some tiny bones, but the bones are not so hard. So you have to fix it like partially. And then the standard recommended procedure for decalcifying trephine biopsies, you take a half, like 50% of the decalcifying fluid of your choice. That is maybe you're using 10% formic acid, and 50% of the fixative that is being used, that is 10% formal saline. And then you mix the two, and then you put the trephine biopsy in a cassette inside that particular fluid. The fluid is containing the fixative and the decalcifying solution for up to 6 hours or overnight. It will not decalcify. And then you continue. After that, you will remove in the fixative, then you rinse it. You remove in the decalcifying solution, you rinse it to remove the decal solution, and then you process it just the same way you're processing the other tissues. Hope it helps.
Thank you. Thank you very much for that. I hope it is well understood because you've explained it clearly. You already tackled the storage, and Aflin Nundu also has just asked the same question, that for how long should histology samples be archived? I think that has been well handled. And maybe you can add something on that, Christine. You see, after maybe they are looking for the cassettes, maybe this was for grossing, yes, but maybe cassettes, the storage. Hello, Christine. I don't know if you can hear me.
Hello?
Hello. Yes, yes. Thank you very
Hello?
much. Yes, I don't know if you can hear me clearly.
I can hear you clearly, John.
Great. Thank you. I just wanted you to maybe respond to, just elaborate briefly. The members have asked about the storage of the samples. Maybe you can also comment briefly on the cassettes, maybe the duration for storage. The presentation was on grossing, yes, but maybe you can just give a slight touch, because maybe we'll proceed in our next presentation to that.
On the blocks, maybe they're asking about the blocks.
Yes.
Blocks that you prepare during blocking or embedding, those blocks, you'll find that in some institution, or it's always recommended that pediatric cases, they use a different code, a different color code of cassettes, and then the adults, they use a different color code. In some cases, it's recommended. But because for pediatric blocks, you are supposed to archive them for up to a period of 50 years. 50 years for PIDs, because you might buy a child might be having a condition at 3 years, and then when they are adults, the condition reoccurs. For PIDs, it's archived for a period of 50 years. Adults, period is 10 years. Period is 10 years. And this one will vary depending on the laboratory or on individual laboratory standard operating procedure, but not less than 10 years. Years minimum.
Thank you very much for that. That's wonderful. This one last question from same Aflin, Aflin Nundu. How do you discard histology samples? I think you talked about this, but you can just also touch on it briefly to get back to Aflin so that she can get it clearly.
Okay. So for histology, wet samples, those are biopsies that remain. You have done your grossing. Once you are done with it, it has been reported, the case has been reported, and then the period your lab lets for retention has elapsed. I said this one is individual. Some labs will keep 2 weeks post-reporting, others 1 month post-reporting, others 3 months post-reporting. The standard period is 3 months post-reporting, because maybe this might take long to reach the clinician or the booking of the patient. The clinic is in 3 months, and then when once the patient presents in the clinic, the clinician is having a doubt on the histology report. So they'll come back to the lab and they'll request for additional tests. So am I audible?
You are audible.
Okay.
You are very clear. Yes.
Okay. So when they request for additional report, maybe, or they always write a review. Yes. Then you have to go back to the gross. Once that period has elapsed, then you discard these samples. These samples, they're normally, you discard the formalin in the sink, because I said the sink should be connected to a pre-treatment tank where the formalin is diluted before it is added in the sewer. So you discard formalin in the sink, and then the wet biopsy, you put them together, maybe in a red biohazard paper, and then it's picked by the public health people for incineration. It normally goes for incineration. Those samples are incinerated. Thank you.
Thank you very much, Christine, for elaborate presentation. Thank you also for attending to the questions and all the concerns of our members. This is quite commendable, and on behalf of LMSK, we say thank you to our members who managed to attend this session. We equally say thank you and really value your presence here. And in addition to that, we also value your growth in terms of the knowledge, skills, and competence as far as medical laboratory practice is concerned. At this point, we are at the tail end, and I would just like to give Christine just a minute to give us a parting shot, and we'll bring it to a conclusion. So over to you, Christine. You can give us a parting shot for just some few seconds or 1 minute or so, and then we will conclude. Over to you, Christine.
Thank you, George. And thank you so much for this opportunity. For our participants, it's always a pleasure to be your host, and we look forward to more interactions in future. Thank you, and have a blessed evening.
Thank you too. Welcome. On behalf of LMSK, one quite interesting. Then we'll allow me to a close. And being a Friday, we wish you on behalf of LMSK